my task is now to introduce a new concept of immune modulatory therapy. We are very familiar with interferon alpha, but I can tell you there are other options, other interferons, which might have advantages in comparison to interferon alpha. So next slide, please. The great advantage of interferon alpha, of course, it's its natural mode of action through the immune system. So we know that interferon alpha, of course, is acting through the upregulation of a number of genes, and these genes then have different activities. They have antiviral activities, but they have also apoptotic activities and immune modulatory activities. And these different activities then are leading to a reduced transcription translation, so this is an anti-proliferative activity. We have elevated apoptosis, and of course we have a number of different proliferative efficacies on the different immune cells, B cells, cytotoxic T cells, MHC upregulation, and so on. So it's a broad immune modulatory upregulation of the immune system, and most importantly, because of that natural way of action, there is no issue with resistance. We have no resistance with interferon alpha, and you have heard a lot about resistance issues with the direct antiviral drugs, and of course this is something we will not discover if we use interferon. However, next slide please, we have different interferons. The typically used interferons nowadays are interferon alphas, but also others, and they all work through the interferon alpha, beta, or omega receptors, and they're all called type 1 interferons. And there are other interferons which act through a separate receptor system, which is the interferon lambda, which is acting through a specific interferon lambda receptor. And this interferon is called type 3 interferons. And the difference between these interferons is that the distribution of the receptors are different. While the type 1 interferon receptors are distributed in the entire body, so at many different tissues, the interferon lambda receptors are mainly only discovered in hepatocytes, so in the liver, but also in epithelial cells. So there are no interferon lambda receptors in other parts of the body, and this might play out in terms of differences in the side effects. Next slide, please. So if we compare the new interferons which are acting through interferon lambda receptors, we have to cover first our knowledge on interferon alpha and side effects caused by interferon alpha. You know that interferon alpha comes in two different pegylated forms, interferon alpha 2b, peginterferon, and interferon alpha 2a, which is Pegasus, and these are the approval studies, these are the efficacies with approximately 54-56% of sustained virologic response. On the next slide, you can see the side effects. I'm sorry for the overview here on this, which is not optimal, but I just will guide you through it and just want to highlight some items. So discontinuation rates with interferon alpha are around 10 to 15%, just due to adverse events. And the adverse events, as you can see, are mainly blood issues like neutropenia, anemia. Of course, the influenza-like symptoms, which are really high, around 50% with initial fever, around 60% with fatigue. We have these musculoskeletal pain issues, around 20%. We have arthralgia, around 30%. So there are many different side effects in that area. We have some gastrointestinal side effects, but most importantly then, we have these psychiatric symptoms, sleeplessness, depression, irritability, and so on. And you can see the numbers. This is a huge problem with interferon alpha. Around 30 to 40% of the patients suffer from these issues. And this is true for peginterferon alpha 2b, but the numbers are very similar also for the peginterferon alpha 2a study. So there is no difference between these two pegylated interferon alphas. So next slide, we can see now what are the potential differences if we use interferon lambda. As I mentioned, the interferon alpha receptor is expressed at all these different tissues, and therefore we have also side effects within the muscle, within the bone marrow, and of course also within the brain. If we look for the interferon lambda receptor, we can see that interferon lambda receptors are not detected in the muscle, are not detected in the bone marrow, are not detected in the lymphocytes, and are not detected or nearly not detected at very low levels in the brain. And therefore, it might be that we don't have all these side effects if we use interferon lambda. However, what we want to retain, of course, is the efficacy in the liver, because the liver is the place where the virus is, and therefore we have to have activity in the liver. And you can see in hepatocytes we have a high expression of the interferon lambda receptor. So that might be an optimal combination. High receptors in the liver and low levels of these receptors outside of the liver. Next slide, please. Next one. So there is an interferon lambda which is available. Interferon lambda was investigated in a large phase 2 study at different dosing levels. It is a pegylated form of interferon lambda. So it's a once weekly injection at 120, 180, and 240 micrograms. It was explored. And this is a controlled randomized prospective study against interferon alpha 2A with the standard dose of 180 micrograms. Patients were enrolled with genotype 1 to 4, and of course, according to our guidelines, genotype 1 and 4 patients received 48 weeks of treatment, while for the genotype 2-3 patients, 24 weeks of treatment are sufficient. Next slide, please. So this is the baseline characteristics for the genotype 1 infected patients. So the majority of our patients, you can see this is a typical Caucasian cohort of genotype 1 and 4 infected patients. The vast majority, of course, is infected with genotype 1. You will see that on the next slide. This is important here. The CC genotype was more or less equally distributed in the different groups, certainly not in favor here for interferon alpha 2A, but more or less the numbers are identical. And on the next slide, then you can see the vast majority. Next slide, please. The vast majority, 94%, got infected with genotype 1, while only a small proportion, 5 to 6%, had genotype 4 infection. Patients with liver cirrhosis were excluded in that phase 2 study, but you can see there is a significant proportion of patients with advanced fibrosis, metavir fibrosis stage 3. So let's have a look on the efficacy. Next slide, please. Here you can see the initial viral kinetics. The red line is the old interferon alpha 2A, and you can see that all 3 groups who received interferon lambda had a somewhat more sharp initial decline. So obviously the antiviral efficacy is high with interferon lambda, and interferon alpha did catch up then only after 12 to 24 weeks. And here you can see at the end of treatment, it looks very similar in terms of antiviral efficacy. So this initial higher antiviral efficacy is also reflected in the numbers of patients who achieved undetectable viral loads on treatment. Next slide, please. You can see that early on at week 4, with interferon lambda, you achieve undetectability rates up to 15-16%, while this was only around 6% with interferon alpha 2A. And then also at week 12, the numbers are significantly higher in comparison to interferon alpha 2A. Around 55-56% had undetectable viral loads with interferon lambda, and only 37% had this same undetectability at week 12 with interferon alpha 2A. At the end of treatment then, and also at the follow-up time point for the sustained virologic response, the numbers then are similar. And obviously, interferon lambda is as active as interferon alpha, with sustained virologic response rates around 40%. So next slide, you can see the efficacy in genotype 2 and 3 infected patients. We know that for genotype 2 and 3 infected patients, 24 weeks of treatment are sufficient and that higher sustained response rates can be expected. And indeed, this was the case with genotype 2. It's typically around 70%, sometimes even higher. And for genotype 3, we know that interferon alpha is maybe not the optimal drug. And you can see this here with interferon alpha 2A, 40% only achieved a sustained response, while PEG interferon alpha lambda was obviously better and more active with sustained response rates up to 57, 70, and here even 83%. The numbers of patients here in the different groups are relatively small, but at least this gives hope that with interferon lambda, maybe because of the higher activity in the liver, we can achieve higher sustained response rates in genotype, and the most difficult to treat patients with genotype 3. Next slide, please. So what about side effects? If we consider the antiviral efficacy is equivalent, the question is there a benefit for the side effect profile? And this looks very promising. Here are the serious adverse events, and you can see this was 7 patients in the interferon alpha group, while in the lambda group, especially in this one here, which was depicted for the phase 3, only 3 patients had a serious adverse event, and overall the numbers indeed are very small here in the interferon lambda treated patients. Next slide. Here you can see the rates of typical side effects caused by interferon alpha. These are fatigue, the musculoskeletal side effects. You have also the insomnia, some rash, arthalgia, and you can see indeed the numbers are much better for interferon lambda. Myalgia, 6% versus 33%, pyrexia, fever, 8% versus 33%, and also here the chills, arthalgia, very low numbers here with interferon lambda at 180 micrograms in comparison to interferon alpha. So obviously the side effect profile is really better. Next slide. Very important, of course, we have to take a look on the liver. If all the receptors are on the liver and you give the same dose, then it might be that you end up with a somewhat higher toxicity in the liver with interferon lambda. And indeed, with the higher dose, 240 milligrams, there was a slight increase of elevated ALT levels, mainly within a range of 5 to 10 times upper the limit of normal. Very few patients had higher elevations, but this was the reason why it was decided not to go forward with that higher dose and to reduce the dose to 180 micrograms in this group. And indeed, the 180 micrograms seems to be the optimal dose for these patients, with no significant increase in terms of ALT and also bilirubin in comparison to interferon alpha. Sorry. Next slide then, what about the hematological side effects? And this is very impressive. The red line always is interferon alpha 2A, and you can see drop in hemoglobin levels, drop in neutrophils, drop in platelets, and for all the different dosings of interferon lambda, there is a much better profile, much less drop of hemoglobin, neutrophils, and platelets. So obviously, this turned out also to be beneficial in terms of ribavirin dose reduction, which was not required in interferon lambda-treated patients, and the same is true here for the neutrophils and for the platelets. So obviously, all these different side effects are no longer associated with interferon lambda. Next slide, please. So what can we do now? If we have a better interferon, maybe we just treat our patients with interferon lambda plus ribavirin. No, that is not the future, because we have already direct antivirals like telaprevir and boceprevir combined with PEG-2A, 2B plus ribavirin. So the next step, of course, would be to take the better interferon and to combine this in a triple therapy with direct antiviral drugs. So what can we take? Of course, BMS, they took their own drugs, which is an NS5 inhibitor and a protease inhibitor. Next slide, please. And they performed a large study with PEG lambda plus ribavirin, plus either the NS5A inhibitor daclatasvir or the protease inhibitor asunaprevir. And this is a typical triple therapy, conventional triple therapy with daclatasvir or asunaprevir in comparison to placebo dual combination therapy with early treatment success patients treated only for 24 weeks. Next slide, we can see the efficacy of that approach, and this looks very promising here. You can see that large numbers of patients achieved high early undetectability of their viral loads with daclatazivir and isoniazid, 33 up to 91% of the patients. At 12 weeks, all patients had undetectable viral loads indeed, and you can see if we look here to the SVR12 rates, which is sustained response, 76, 75%. These are the numbers we know from tenofovir, boceprevir. So obviously, this triple therapy is as effective as the conventional triple therapy we are currently using, with, of course, the advantage that interferon lambda is much better tolerated than interferon alpha. Next slide, please. So what is then the next step? This is the conventional triple therapy. We have seen that this can be significantly improved with the help of interferon lambda. Of course, the question is, can we also treat our patients just without interferon-free? And you have seen already some studies yesterday. I just want to remind you that with these two drugs here, daclatazivir and isoniazid, the NS5 inhibitor, the protease inhibitor, for the very first time in a small study, of course, it was proved that you can eradicate the virus without interferon alpha. In 1A patients, we ended up with some breakthroughs, but some 1A patients achieved a sustained response. All 1B patients achieved a sustained response. So for the very first time, this proof of principle study showed us, yes, we can cure our patients without interferon alpha. And of course, based on this experience for the first time, then many other studies were initiated. Next slide, please. To repeat this success, so different companies with different combinations. For example, here, daclatazivir isoniazid was combined with a non-nuke, and you can see we can achieve very high sustained response rates. But all these studies typically enroll easy-to-treat patients, and of course we want to know how effective are these drugs in the more difficult-to-treat patients. And you can see that difficult-to-treat patients are redefined. We have learned that cirrhotic patients are difficult to treat, but next slide, you can see that also genotype 3 patients are difficult to treat. You have seen that study yesterday, the genotype 2-3 infected patients with sofosbuvir plus ribavirin. Next slide, for 12 weeks. And in genotype 3 patients, this was really a disappointment. 61% only with no cirrhosis, and even only 34% with sofosbuvir plus ribavirin in the cirrhotic patients. I think we can do better than this. We have had data already with daclatazivir plus sofosbuvir and genotype 3, ending up with more than 90% sustained response. And finally, I want to show you some data on, next slide, sofosbuvir plus daclatazivir. Next one, please. In the most difficult to treat patients, I would consider failures to boceprevir and tenofovir to be really difficult to treat because we don't have anything to offer to these patients so far. And this is a very first study addressing these patients. We have issues with non-responsiveness to interferon alpha if they fail to a triple therapy. We have issues with, of course, resistance mutations in these patients. And, of course, we want to know, can we cure patients who failed to boceprevir and tenofovir? And this is a study using different approaches with and without ribavirin, combination therapy of daclatazivir plus sofosbuvir for 24 weeks. And you can see these are all true failures to tenofovir, boceprevir, and many of these patients really harbored resistance mutations against the NF3 protease up to 50%. It is a small study with 41 patients only, but I think it gives hope because on the next slide you can see that this is highly effective. The patients are going down with the viral loads very quickly at week 4. They are all undetectable. This stays to be true until sustained response 12 rates. And here you can see we get around 100% of cure in these difficult to treat patients. So next slide, ladies and gentlemen, in summary, we have learned that interferon-based treatment options have a unique mode of action with the advantage of a broad immune response which is induced by interferon, and we have no issues with resistance. And I think it could well be that for the most difficult to treat patients, we will need this immune modulatory therapy. Interferon lambda has some advantages because it has the advantage of the different distributions of the receptors. There is an equal, at least equal antiviral efficacy together with a much better safety profile. And we have seen that triple therapies with interferon lambda, ribavirin plus direct antiviral will be at least as good as the standard conventional triple therapies, but is better tolerated, of course. And finally, we have seen that even interferon-free treatment options can be very effective, but of course our experience is limited, especially in difficult to treat patients and especially in cirrhotic patients. Thank you very much.